All right, I think we're going to go ahead and get started. So good afternoon, everyone, and welcome to today's webinar from MICIS, focusing on the 2019 legal opioid update. Today's speaker is Peter Michaud, who I will introduce a little bit later on. There we go. Just a reminder for CMEs today. Today's speaker does not have any relevant financial relationships with the manufacturers of any commercial products and or provider of commercial services discussed in this CME activity. CME will be available for participants who have signed into the live webinar. If there are multiple people watching at one computer, you're sharing an office with a bunch of people, please make sure to type their names and email addresses into the chat box so that we can make sure to record your attendance for today. We do not have separate nursing CEUs, but you can still receive the CME certificate. Once the webinar has been ended by the host, a pop-up will appear on your screen that will immediately direct you to the survey. If you decide to close the meeting before we do, that link will not pop up. So please make sure to stay on and wait for us to close the meeting. You will have 2 weeks to complete the survey. The CME documentation process, you will be immediately able to download the CME certificate on the last page of the survey. If you have any issues, you can contact Jackie Tyner at her email address is there on the screen if you have any questions or problems. So important notes for today's webinar. You are in listen-only mode, so please make sure to use the Q&A function to ask questions or make comments. The video screen size is adjustable, so if there are some boxes that might be in your way, you can move them around to make it the most comfortable for you. And again, if you are joining by phone or with others on the same computer, please make sure to put your information in the chat box so that we can give you credit for today. Just our funding statement, this webinar is funded through a contract from the Maine Department of Health and Human Services. And a little bit about Qualidime. So in January of this year, Maine Quality Counts merged with Qualidime. We are a mission-driven national healthcare consulting organization with multiple offices across New England. We have over 35 years of experience in improving healthcare delivery. We specialize in quality improvement, project management, and technical assistance. And we have served as the Medicare QIO in Connecticut since 1983 and the Northern New England Practice Transformation Network since 2015. So just to go over some of the objectives for today's webinar, we will review the impact of Chapter 488 in Maine, discuss opioid laws, rules, and initiatives of the new administration, study Chapter 21 requirements and logical implementation, and investigate methods to further transform local and regional prescribing. And last but not least, I'm going to introduce today's speaker. Peter Michaud is a nurse and attorney who currently serves as general counsel of the Maine Medical Association. His work involves government regulations, public health policy, and legal analysis on behalf of the association's 4,300 physician members. So obviously there's more on his bio here, which you guys will all receive the slides tomorrow after the webinar. So with that said, I will pass it over to Peter.
Thank you, Morgan. Let me see if I can find my presentation here. There we go. Okay, so today we're going to be talking about Maine laws and rules and regulations on the prescribing of opioids. And, oh, there we go. Okay. No financial relationships to disclose. And here's the difficult truth at the moment. We're still a long way from solving problems, regardless of how hard we've been working and how much attention we've been giving to this issue. The death rate from drug overdoses has come down from 2017 to 2018, but it still has a long way to go. If you look at this graph, it also shows deaths from traffic accidents and homicides in Maine. And imagine what would happen if we had 354 homicides, or if we had 354 traffic fatalities in Maine. I guess there would be significant reaction, significant panic among various lawmakers. That's why we are where we are. And it's not just the people who are actually taking the drugs who are affected. 1 out of every 14 babies born in Maine in 2018 was born drug affected. That's a reduction, and in fact, it's a 2-year reduction, as you will see from this slide. But we're still way above several years ago. We are now down to between the 2012 and 2013 rates. Nationally, the number of drug-affected births has continued to rise. And this graph is a little bit hard to read because the number of states reporting has changed. That's the orange line. So you can see the number of states reporting went up as the number of drug-affected births went up. Then from 2011 to 2012, although 1 fewer state was reporting, the rate of drug-affected births continued to increase and increased over the next couple years when the reporting states were flat. And then again, as the number of reporting states increased. And there's no question that we were over-prescribing opioids. If you look at these numbers from publications in 2016, 75% of partial mastectomy patients did not take any of their prescribed opioids post-surgery. The same was true for 34% of lap cholecystectomy patients. But the most concerning figure on this page is the wisdom tooth extraction patients. Think for a moment about the demographics of the situation. Who's having their wisdom teeth out? Mostly older teens and young adults. Compare that with the idea that the human brain does not complete its development until the age of 25 or 26, and the last functions to be completed in their development are executive functions, judgment, things of that nature. So we had patients receiving 20 pills but only using 8 of them, and those same patients have undeveloped or lesser developed judgment functions. What happens then? Many of these patients probably have friends who would be more than happy to buy their unused opioids from them. We also need to consider that in this rural state, we are more at risk because the rates of overprescribing are highest in rural counties. In fact, across the nation, 14 of the 15 highest rate counties were rural. So why did we need a law? Well, we needed a law because we weren't doing enough to govern ourselves. In early 2016, over 16,000 Mainers had prescriptions for more than 100 morphine milligram equivalents per day, and 1,200 Mainers were over 300 MMEs. Now note, these figures do not include the prescription of opioids for medication-assisted treatment, but only for pain treatment. So when these figures came to light, when we started to see newspaper articles and TV stories about it, the government started to act. And an interesting thing happened in late 2015. 3 people got together to do something about increasing opioid overdose deaths. Those 3 people were the U.S. Attorney for Maine, the Maine Attorney General, and the Commissioner of Public Safety. Now, the Department of Public Safety is where the state police reside in state government. They formed the Maine Opiate Collaborative, and they brought other people in to work with them, who were divided into 3 task forces: treatment, prevention and harm reduction, and law enforcement. And they did that job very well, because what they did was they brought in addictionologists for the treatment task force. They brought in people from people who were in recovery for the prevention and harm reduction task force. And they brought in county sheriffs, police chiefs, DEA people for the law enforcement task force. Those task forces then brought in other witnesses, heard from a lot of people about the situation, gathered together what they thought was the best possible responses to the opioid crisis, and issued a report to the legislature. At the same time, in early 2016, Governor Paul LePage proposed major opioid prescribing legislation and established a program of opioid health homes. There were intensive negotiations around the proposed legislation because there were many parts of it that physicians and other prescribers didn't particularly like, that people didn't think would be the best response. So after those negotiations, after hearings in the Committee on Health and Human Services in the legislature passed and Governor LePage signed Public Law 2015, Chapter 488. The law went into effect on July 1st, 2016. A little bit later, the licensing boards became involved, and they passed Chapter 21 of the licensing rules and regulations, which became effective on March 24, 2018. In the past year, we had an election in the fall of 2018, and Governor Mills named Gordon Smith, my former employer at the Maine Medical Association, her director of opioid response. Gordon's sole purpose is to address the issue of the opioid crisis. At the same time, the opioid health home program was continued and increased. Those health homes include integrated care management with office-based medication-assisted treatment and counseling, so that you have both the medication side of the treatment process and the counseling side. Funding was increased in 2018, and now we have 32 programs in 71 locations in Maine. As of about 4 months ago, we were serving 1,740 individuals in these programs. At the same time, the DHHS increased reimbursement rates for providers. There was increased federal funding from a number of different sources in the federal government. And some interesting things happened in the correctional sphere. First of all, Randall Liberty was appointed to be Governor Mills' Commissioner of Corrections. He set about establishing medication-assisted treatment programs in the state correctional facilities, the state prisons. Now, in Maine, the county jails are not run by the state, they're run by the individual counties. And there were varying responses to MAT in the jails. Some counties embraced the idea. Some counties resisted the idea. And last year, a young lady in Aroostook County who was involved in medication-assisted treatment, she was in treatment, was arrested for something, was convicted, and sentenced to a term of days in the county jail. The Aroostook County Sheriff, who's responsible for operating the jails, said that he did not want any drugs in his jail, and that included drugs used for medication-assisted treatment. Ms. Smith's case was taken up by the American Civil Liberties Union and tried to a federal judge. The federal judge issued a decision that required the county jail to allow medication-assisted treatment during the period of incarceration. The county appealed the case to the U.S. Court of Appeals for the First Circuit. Now, for those of you who don't know how the circuits work, each state's federal court is part of a federal circuit governed by an appeals court. Maine's federal circuit includes all the other states except for Vermont and Puerto Rico. The case was appealed to federal court, the Circuit Court of Appeals, which issued a very brief decision almost immediately upholding the federal judge's decision. A significant part of the case before the federal district court judge was the use of what's called a friend of the court brief, or an amicus curiae brief. In that brief, the attorneys presented the medical information underlying medication-assisted treatment. Why the medical world considers MAT to be safe and effective. In other words, it's a way to educate the judge about the non-legal aspects of the case. And that brief, which was joined in by, among others, the Maine Medical Association and the American Medical Association, was very important in educating the judge and helping to bring her to her decision. So, Chapter 488 is the bill that was passed in 2016, became effective July 1st of 2016. There's a link to it there. In brief, I mean, most of you have been living with this law for 3 years now, so I'm not going to go into great detail about it, but let's just review it quickly. What does the law require? It requires you to check the PMP, the Prescription Drug Monitoring Program. It sets limits on the number of morphine milligram equivalents which can be prescribed per day. It sets limits on the length of time for which opioids can be prescribed, 7 days for acute pain, 30 days for chronic pain. And it establishes some exceptions. The legislature was very smart in the way it approached the idea of exceptions, because it established certain exceptions and then left room for the Department of Health and Human Services and the licensing boards to allow additional exceptions if they felt those were necessary. To give you an idea, a quick review of the structure of government in the US, and the federal government is essentially the same structure as the state government. You have at the very top level the Constitution. The constitutions of both Maine and the US were written by a group of people, all of whom are now dead. They involve general statements of principle. The second level is the level of statutes, statutory law. Those statutes are passed by legislatures, so the Maine legislature or the US Congress. They are somewhat more specific than constitutional provisions, but they are still fairly general. Remember that in Maine we have a citizen legislature, so although we do have in the legislature 5 physicians, a nurse practitioner, and a registered nurse, most of the legislators don't have medical backgrounds. They are teachers, they're farmers, they're engineers, they're lawyers, and they bring their expertise in those areas, but they don't have education and training in technical medical issues. So statutes are still somewhat general. The very bottom layer of law in the state of Maine is that of rules and regulations. Rules are passed by departments or by licensing boards. Those organizations are made up of individuals who have greater expertise. So the people in the Department of Health and Human Services who work on opioid rulemaking are people who know something about opioids. The licensing boards for medicine, for osteopathic medicine, for nursing, for podiatry are made up, at least in large part, of physicians, podiatrists, advanced practice nurses, other nurses who have some knowledge, have some specialized knowledge in the field. So those rules are much more specific than statutory law or constitutional law. That's why when we talk about laws being unconstitutional, it means that the statutes don't comply with the higher level of Constitution principles. The same is true of rules. They have to comply with the statutory level. Otherwise, they're invalid. So the Department of Health and Human Services established these exceptions and allowed for the establishment of other exceptions by the department. And that happened. Other parts of the statute, partial filling of prescription is allowed at patient request. And in giving this talk around the state, I've seen some places where very few people have said that their patients have asked for partial fill. I've had other places where quite a few of the prescribers say, oh yeah, several of my patients have asked for only a partial fill of their prescription. Remember the part of the law here, if you do fill only part of the prescription, the rest of it is invalidated. If someone fills part of it and then feels they need more than they thought, they go back to the pharmacy, they will not be given additional medications. Mandatory CME, which is why we're still here, and mandatory electronic prescribing. As time has gone on over the last 3 years, electronic prescribing has gotten better and better. We used to have significant issues with systems talking to each other, EHR systems communicating with electronic prescribing systems. Those are getting much better. There are exceptions to the PMP check requirement. Remember that Chapter 488 requires a PMP check for opioids or for benzodiazepines. This is the only part of the law that relates to benzodiazepines. They have to be checked before, it has to be checked before initial prescription and every 90 days thereafter, while the meds are still being prescribed. But no PMP check is required if the benzodiazepine or the opioid is directly administered in certain settings. And those are settings that entail a higher level of scrutiny over the use of the medication. So in an inpatient hospital setting or a residential care facility, what you have is the nurse going up to the patient or the med tech and saying, here are your pills. Here's your glass of water, please swallow, while I watch, of course. And there is very little opportunity for the patient to divert or misuse the medication. And tonguing meds is always a possibility, but people who work in inpatient settings are aware of that and look for it. Remember, the whole purpose of many parts of this law is to prevent misuse or diversion. PMP checks are also not required for hospice or end-of-life patients. Those are situations, again, where there is daily scrutiny of the use of the medication, and so less opportunity, less likelihood of diversion or misuse. There are still some exceptions to the e-prescribing requirement, mostly having to do with technical issues. If your system crashes and your electronic prescribing software is not working, you can't very well prescribe electronically. In long-term care, the age-old practice has been to prescribe via fax. That's continued. It used to be that the VA pharmacy system did not communicate well with electronic prescribing systems, and so there was an exception for that. Nowadays, those systems work well together, so that's not a problem. Remember that if you have an exception from the limit requirements or from the PMP check requirements, that does not mean you have an exception from the requirement to prescribe electronically. Chapter 21 of the Licensing Board rules is very specific and should be reviewed by anyone who prescribes any opioids at all. The link is there for you to check, and if you have not read the entire chapter word for word, I suggest that you do so. What does it do? Well, it defines terms. It does some things that are fairly obvious. For example, it requires that you achieve and maintain competence in assessing and treating pain. Well, I mean, just as a practical matter, if you're going to be assessing and treating pain, you need to have a certain level of competence. So while that's obvious, it's still stated in the rule. It requires that you consider the use of non-pharmacologic modalities or non-controlled drugs in treating pain before you consider using controlled substances. And one of the major things it does is require the use and documentation of universal precautions in prescribing controlled substances. Now, many of you are probably like me. When you hear the term universal precautions, you think infection control. When I first saw this in the rule, that was exactly what I thought. And so I went to the executive director of the Board of Licensure in Medicine and asked him what this was about. Well, he told me that it was a term that was used for opioid prescribing, so I did a little research. And it turns out that back in 2005, there was a physician who was looking at opioid prescribing practices, because even then, people were starting to take notice of issues. Overdose deaths were going up. There were problems that were starting to appear. This particular physician was studying the issue, was aware of the idea of universal precautions in infection control, and thought, wouldn't it be neat if we had universal precautions for opioid prescribing? So he wrote a paper and put forth that proposal. The proposal was taken up by licensing boards around the country, and first thing you know, it was in fairly common use around the nation. That's why the state of Maine is doing it. Now, it's important to note that the licensing boards are currently looking at modifying Chapter 21. Some issues were raised by various practitioners. I'm happy to say that we at the Maine Medical Association were instrumental in presenting those objections to the boards. They listened to us and they are making changes. They will be exempting custodial care in nursing homes and hospice care, and also they're making some changes relating to cancer care in terms of applying the rule to opioid prescribing. It's not done yet, so the form of the rule that went into effect in 2018 is still effective now. But I'm expecting, my rough guess is that by the end of this year, we may see the changes having been approved by all the prescribing boards and gone through the public comment process and become effective. If it's not by the end of the year, it'll be shortly thereafter. So what are these universal precautions? Well, you have to include in every patient where you're thinking about prescribing opioids, you have to do an evaluation, you have to have a treatment plan, written informed consent, of course, the PMP check. If you're treating for chronic as opposed to acute pain, you need a treatment agreement or a contract. You need to use drug screens and the ever-present documentation requirement. As part of the patient evaluation, your history and physical have to be very detailed, and you need to document those details. What's the pain like? Duration, location, nature, intensity. How does the pain affect function, both physical and psychological? Are there comorbidities? Are there intolerances or allergies? Is the patient using other substances, whether legal or illicit? What do you have for lab results, other tests? Have there been past pain treatments or consultations? Is this not the first time around for this patient? You need to document at least one recognized medical indication for the use of controlled substances before you prescribe one. And you need to make sure that you note all other medications being used by the patient. In assessing risk, if you're prescribing for acute pain, then a basic consideration of short-term risk is sufficient. And the rule really leaves it up to the individual prescriber to decide what that means. If you're prescribing for chronic pain, the assessment is more detailed. But in both circumstances, you have to think about whether the benefits outweigh the risks of using opioids, include factors that are involved in this patient's overall level of risk. If you're prescribing for chronic pain, they recommend but don't require that you use a risk screening tool. But the rule also says you should consider all of these factors in your risk assessment. And not just the individual's history of substance use or misuse, but any family history. You know, is there any behavior in the family, perhaps by parents, which might put a patient at higher risk of developing a substance use disorder? Has the patient been the victim of any physical or sexual abuse? Those kinds of things might make it more likely for the patient to develop a substance use disorder. Are they using other substances? Think about tobacco, think about vaping, alcohol, not just other drugs. Does the patient have any other psychiatric conditions, especially poorly controlled depression or anxiety? If you think that may be the case, you may want to use a depression screening tool. And is the patient regularly using other central nervous system medications or other central nervous system substances such as alcohol, medical marijuana, things of that nature? Is the patient getting opioids from more than one prescriber? Now, these are things that you have to consider. It doesn't mean that they're necessarily contraindications to prescribing opioids. If I'm your patient and I live in Maine for the summer and in Florida for the winter, and I get my prescriptions for pain medication from you during the summer and from a different physician in Florida for the winter, if you don't see any other indicators of problems, that's probably perfectly fine. But it's something you need to think about, look at, ask about. Has there been aberrant behavior regarding opioid use by your patient in the past? Lots of emergency department visits, looking for pain treatment. And it's not just a substance use disorder risk that we're looking at. It's risk of other problems too. Falls and fractures. Is your patient older and suffering from osteoporosis? Does your patient have balance issues? Does your patient have respiratory risk factors that might raise the risk level of prescribing, of using opioids? All the comorbidities. Does your patient have liver, kidney problems that might affect the clearance or metabolism of the opioids, therefore raising the level of opioids or their byproducts, some of which are psychoactive, in the person's bloodstream? I know a person who's rather elderly, he's in his mid-90s, who fell and hurt himself, was in significant pain, and so was prescribed tramadol, a pretty low-level opioid. But his kidney function is such that he wasn't clearing one of the psychoactive metabolites of tramadol. Over the course of days, his behavior became more and more problematic. His cognition declined, and this is someone with Alzheimer's disease, so there was limited cognition already, limited ability to self-assess that there was a problem, to the point where the patient had to be hospitalized. When he was hospitalized, the tramadol was discontinued. Eventually, the metabolites cleared, and his baseline level of cognitive function returned. So those are all things that one needs to think of. Possible pregnancy, of course, is always an issue. And you must document in the patient's medical record a statement that the risks and benefits have been assessed. Do you have to list every single risk and benefit that you've assessed? Well, perhaps not. But I would suggest, with my lawyer hat on, that you are going to want to be able to say what you did if you're ever asked, especially if you're asked on the witness stand. So either document in detail what you did, or have a checklist that you use in every single case, so that if you're ever asked about it in the future, you can say, well, my assessment of risks and benefits in cases where I'm thinking about prescribing opioids always include these things. You need a treatment plan, and you need a plan whether you're prescribing for acute or for chronic pain. What are your objectives? How are you going to tell whether your treatment has been successful? What are your functional goals? Are there other diagnostic evaluations or other treatments that you think are important or necessary? Did you discuss the realistic outcomes and expectations with your patient, including the expectation that your patient will engage in regular physical activity to help to deal with the pain? A lot of times, patients will, as you know, resist any kind of movement because it hurts. And so while they think they're doing better for themselves by resting the body part that has pain, they're in fact most likely interfering with the healing by reducing the activity. Remember to prescribe the lowest possible dose to an opioid-naive patient and then titrate up to effect using functional assessment. Always begin with the immediate release form rather than the extended release form, and we'll talk more about that in a little bit. For chronic pain, it's a good idea, they say, to present the treatment as a therapeutic trial for a shorter period of time and then reevaluate. Okay, Mr. Jones, we're going to be trying this medication to deal with your pain. I'd like you to take it the way I've told you for 3 weeks, for 4 weeks, and then come back and see me. We'll talk about how it's going. If this treatment is working well for you, That's great. If it's not working well for you, then don't worry. We have other things we can try. The idea is you don't want to set up an opioid as the be-all and end-all of pain treatment or some type of magical answer to the patient's problems. In those circumstances, you end up with unrealistic expectations. The patient may think, well, if this pill doesn't work, maybe if I take 2 of them, it'll work better. You want to avoid that. And so you present it as something we're going to try. This is an important point. If you inherit a patient from a colleague, you must reassess that patient. It doesn't matter how much you respect your colleague, how expert your colleague is in the use of opioids for pain treatment. If a colleague moves away or retires and you inherit the patient, even if the patient was assessed 2 weeks ago by your colleague, you must reassess that patient. Now, this doesn't mean you have to reassess every time you cover for a colleague who goes on vacation or who's away for a weekend. But if you inherit the patient, you should. Periodic review. You should review your patients. In fact, you must review your patients at least annually. Even if you have a patient who has been on a very small dose for a long period of time, decades even, the rule requires that you reevaluate annually. And in fact, the rule also requires that you perform drug screens at least annually based on the patient's risk. So if you have an elderly patient who's on a tiny little dose of tramadol every evening for her leg pain, and there's been no issue of misuse or diversion, everything seems to work well. She has tried to not use the tramadol and she finds that she has more pain. You still have to do drug screens on this patient annually. If you have a patient where there's a higher index of suspicion of perhaps diversion, then you want to assess and do your drug screens more often than annually. The rule says that random pill counts are an additional tool. It doesn't require that you use them, but it suggests that they are there for a purpose, and you should include them in your thought process when you're deciding how to assess your patient. If you have a patient who's higher risk, a patient who maybe is more complicated than you're used to, there is no shame in consulting or referring the patient out to someone else to get some help with the case. In a case where you're prescribing for chronic pain, the informed consent requirements are very specific and very extensive. Again, I suggest that you go to the rule and read the requirements. You need to consider the benefits, both in terms of reduced pain and in terms of improved function, and the various risks. Now remember, informed consent means that you need to discuss all of these things with your patient. What are the potential side effects? Will they be operating a vehicle? Do they have any allergies? What else are they taking? Is there something that might interact badly with the opioid you're about to prescribe? Discuss the idea of tolerance, the risk of addiction or overdose, withdrawal. What happens if they stop the medication abruptly? Where do they live and in what circumstances? Do they have 4-year-old grandchildren who love to climb up on things and maybe go into medicine cabinets and find things? Do they have older grandchildren who might be interested in what these drugs will do? That famous age of experimentation. You need to discuss all of these things with your patient. And if you're treating for chronic pain, you also need a contract. And these items in this list are the requirements, not just suggestions. There's that second one, requirement of patient discretion in possessing and storing controlled medications to avoid theft. The idea of taking only as prescribed and avoiding other substances. What are your expectations of the patient in this contract? It's very important that the patient be very clear on what your expectations are, so that if there's a violation, there's no room for, well, I didn't know, or I wasn't aware that you didn't want me to do this. I thought it was okay. Some of those requirements, that the patient keep their appointments, that they comply with pill counts and drug screens. If you're using those things, the expectation should be clear. The agreement should also include a statement that the clinician may notify proper authorities if there's a concern about illegal activity. You know, especially in the psychiatric world, we have an obligation to notify people, whether that be the authorities or potential victims, if a patient makes credible threats of harm to another person. Think about opioid prescribing in the context of diversion. Is there a risk to other people? There may be. If there is, then you should certainly consider the idea of informing the authorities to avoid risk of harm, risk of overdose, risk of death perhaps to other people. Of course, your documentation has to be detailed. There are all these things that you need to include: the results of your risk assessment, your PMP checks, all treatments and medications provided, and that includes non-pharmacologic treatments. What have you tried? How did it work? How did it not work? Whether you've had consultations with specialists, and any other information that you used in making the decision about whether to prescribe opioids. Now, the current form of Chapter 21 has this provision that requires clinicians to be aware of and follow the CDC guidelines. Now, the CDC guidelines have been clearly stated by the CDC to be just that, guidelines and not requirements. That's another issue that we raised to the licensing boards. We are expecting that language to be changed to remove the mandatory language about you must follow the guidelines and replace it with a strong suggestion that you know about the guidelines and that you use them in your thought process. And this is what I was talking about a moment ago. You have a basic duty of confidentiality to your patient. However, if there's a risk of harm to a third person, then the confidentiality obligation may give way to the duty to report. Now, what's been happening with opioid prescribing? Remember, our politicians in Maine got involved in late 2015 and early 2016. Well, the medical community was noticing problems before that. Opioid prescribing peaked nationally in 2012. Maine at that time led the nation in the rate of long-acting opioid prescriptions. We have declined. And in 2017 alone, we saw a decline of 13.2% in opioid dosing. So we are making progress. This chart shows the blue bar is Maine, the orange bar is national average, and the gray bar is the lowest state. So you can see how much more than the lowest state Maine was prescribing opioid medications, and how far above the national average we were in long-acting prescriptions. High-dose prescriptions, we were a lot closer. Now, what happened in 5 years? The numbers went down. We are still way above the national average in long-acting opioid prescriptions. So, as I said on the first slide, we still have a long way to go. Now, the reason there's an uptick from 2018 to 2019 is, well, there's one reason that we know of and one reason that may be suspected. First of all, you'll note that these numbers include prescriptions for medication-assisted treatment. So while the opioid prescriptions went down, number of patients, there was an uptick, which may be people who were using street opioids who are now in medication-assisted treatment. But also the 2019 figure is an estimate based on the first 6 months of the year. So that uptick may not hold out when we have the full year figures. We'll have to wait and see. Retail opioid prescriptions, both in number of prescriptions and rate per 100 persons, have gone way down over the last 5 years. But have we gone too far? There's a reason I use this very complicated diagram of a pendulum, because the question about whether we've gone too far in our restrictions is not a simple one. There are a lot of things we need to think about in looking at that issue. We have conflicting public health crises: the crisis of substance use disorder and the crisis of chronic pain. And individual practitioners, practice groups need to think about these issues. Is it ethical to just decide, oh, well, this is too complicated, this is too much of a hassle, I'm just not going to prescribe opioids? Is it ethical to wean an elderly patient from an opioid when their function has been well maintained for years on a certain level, when there's really been no issue of diversion or misuse ever? Is it better for the patient to not have opioids, to have a lower level of opioids, or is it better for the patient to continue at a level where their pain is under control and their function is good? We are seeing a lot of circumstances now where a patient is on opioid treatment for pain. The prescribing practitioner, whether it be a nurse practitioner, a PA, a physician, goes away, leaves the state perhaps, or retires, and that patient cannot find someone to take over their treatment because people do not want to take on patients who are already on opioids, especially if they're on higher level of opioids. Think about the ethics of that situation. These are hard questions, but I want you to think about something. Those of us involved in the medical community are paid much better than most of the people around us in our communities. We're also very highly respected. And among the most highly respected people in society are nurses and physicians. So we get the benefits of those aspects of what we do. Along with those benefits come obligations. We are obliged, we are, I would say, required to make the hard choices, to do the hard work that's involved in our professions. Sometimes that means taking on the hard patients. So I ask you all, when you're deciding what to do about a particular patient or what to do about a particular policy of your practice, remember your station in society, remember what society gives you, and remember that you owe society, that we all owe society a debt in return of doing the hard work that our professions involve. And some of that hard work may include getting your X waiver and doing medication-assisted treatment. You know, physicians who do a significant amount of medication-assisted treatment, many of them have told me it's the most rewarding part of their practice. It's hard. It's a relapsing disease that we're talking about. But when it works, when the treatment process engages and becomes effective, it can be very rewarding work. I've got some links here for other resources that you might be interested in, both in terms of the history of the law and various types of tools you may find. And I'm happy to address a few questions. We have 4 minutes left, I guess.
Thank you. At this time, we actually don't have any questions in the Q&A or in chat, but if you guys, if you have any questions, please put them in chat or Q&A and we will be happy to address them. So we'll give it just a couple more minutes to see if anyone enters a question. I'm not seeing any. Oh, let's see. Actually, somebody just asked if the webinar will be available to watch again. Yes, we will be sending out a link to the recording in a follow-up email tomorrow. Let's see, that's kind of it. There aren't really any more content questions, so we'll just kind of go through. Let's see, in chat. Okay, somebody just asked in chat, do some practices limit their quantities to 28 days?
I'm sorry, could you repeat that question?
Do some practices limit their quantities to 28 days?
I have heard that some people limit to 28 rather than 30 days because it makes it more convenient. That way you don't have a period that ends on a weekend or a holiday. So yeah, that's perfectly appropriate.
That makes sense. Right. Let's see. Do we have any other questions? I think those are all. Oh, another one. Could you expand on the differences between acute and chronic pain? When does it become chronic?
Well, that's really a clinical determination rather than a legal one. And since I am not a nurse practitioner, just an RN who hasn't practiced clinically in 5 years, I really don't feel competent to answer the question. I will say that from what I've heard, the pain is considered to be chronic from acute after treatment for roughly 3 to 4 weeks. That's when people start thinking about, well, maybe we're not dealing with an acute process here, we're dealing with a chronic process. Maine Care may have some specific requirements on it. I don't have the Maine Care regulations in front of me at the moment. But if you're treating a Maine Care patient, you'd want to check those.
Excellent.
We'll send a link if we can.
Okay, great. We can actually put that in the follow-up email that goes out tomorrow. So if you want to just get that to Jackie, we can get that out. We had another question that came in. Why are pharmacies allowed to dispense 2 days in advance?
In advance of what? I'm not sure. You mean overlap, perhaps?
Ashley clarified and she said, why are pharmacies allowed to dispense 2 days in advance of the actual fill date?
Okay, I imagine that is because of people traveling, things of that nature. There is some leeway allowed, and I generally advise prescribers, not pharmacies, so you'd want to check the pharmacy board rules on dispensing issues. But my guess is it's probably because of convenience factors, you know, with limitation. I mean, 2 days is one thing, 20 days would not be a reasonable number.
Excellent. So it looks like those are all the questions we have. Again, if you guys can make sure to stay on until we close the webinar so that you can get your CMEs. We just wanted to let you know of our next webinar that's coming up on November 19th. Co-prescribing benzodiazepines and opioids, the black box of increased overdose risk. We will include a link to register for that webinar in the email that goes out tomorrow, so make sure to sign up for that. And here is all of our contact information if you need to reach out to us for any reason. And last but not least, make sure to follow Qualidime on social media. You can see all of our channels and our handles there. But thank you, Peter, for that wonderful presentation, and everyone for joining. Have a good rest of your day.